Pediatric Thyroid Disorder Part 1. In this lesson, I will discuss about hypothyroidism. Hypothyroidism is thyroid hormone deficiency, and it can be central or primary. In central, there is low thyroid stimulating hormone, whereas in the primary hypothyroidism, it is due to defect in the gland or hormone. And it can also be congenital or it can be acquired. In the case of congenital hypothyroidism, it is present at birth, whereas in the acquired one, it occurs later in life. To start from congenital hypothyroidism, the prevalence of congenital hypothyroidism is around 1 in 3,000 to 1 in 4,000. It is slightly female predominant, and the female to male ratio is 2 to 1. And the majority of cases of congenital hypothyroidism is caused by thyroid dysgenesis. So, when we say etiology of congenital hypothyroidism, as we have said, the majority of congenital hypothyroidism is due to thyroid dysgenesis. In the case of thyroid dysgenesis, 33% of cases are aplasia. The remaining 66% are hypoplasia or ectopic gland, which can be found at the lingual or sublingual area. And the cause for thyroid dysgenesis is mainly unknown. And there is some underlying genetic component which predisposes the patient for having thyroid dysgenesis. The next cause of congenital hypothyroidism is defect in thyroid hormone synthesis. This is responsible for 1.5% of congenital hypothyroidism, and it is mainly autosomal recessive inheritance. And those who have defect in thyroid hormone synthesis, they have goiter, and they are characterized by having goiter. The other is iodine deficiency, and the other cause of congenital hypothyroidism can be TRH and TSH deficiency, maternal autoimmune disease, radioiodine therapy, thyrotropin antibodies, iodide transporter abnormalities, deiodination, thyroid peroxidase deficiencies, thyroglobulin deficiency, and thyroid hormone transport problems. When we see the clinical manifestation of congenital hypothyroidism, usually they are asymptomatic at birth, and later they can cause enlarged anterior fontanelle, prolonged physiologic jaundice, poor feeding, which can predispose for choking and decreased interest, poor weight gain, and respiratory distress due to macroglossia, nasal obstruction, and episodes of apnea. They are also characterized by decreased activity. They do not cry a lot. They have excessive sleep pattern, and myxedema, which is mainly seen around genitalia and the extremity and also eyelids. Constipation with large abdomen and umbilical hernia is also characteristics of congenital hypothyroidism. Low temperature with cold and mottled skin, especially extremities. Skin might be dry and scaly with little perspiration, and 10% of neonates who have congenital hypothyroidism have concomitant congenital abnormalities, mainly shunt lesions such as ACD and VSD. Congenital goiter can also be seen, and the physical and the mental retardation progresses, usually evident by 3 to 6 months of age. The next is about investigation of congenital hypothyroidism. T4, which can be free or bound, is decreased, and as in all cases of hypothyroidism, TSH is elevated. And we can also see location of thyroid gland in the case of ectopic thyroid by thyroid scan, and also thyroid ultrasound can be used. Maternal and neonatal anti-thyroid antibodies if indicated, and we can also check for long bone ossification, which is mainly delayed ossification by X-ray. And always we should not forget to test the identical twin if they are a twin. Regarding the treatment of congenital hypothyroidism, optimal to identify and start treatment before 2 weeks of age to prevent reversible brain damage with levothyroxine or T4, 10 to 50 microgram per kg per day. And overtreatment with this levothyroxine causes risk of craniosynostosis or problem with temperament, and this T4 is converted to T3 at the periphery, and it is used for the whole activity of the thyroid hormone. On outpatient follow-up, T4 and the TSH should be measured 4 to 6 weeks after initiation of therapy, then every 1 to 3 months until at least 3 years of age. and we should have to decide whether to discontinue or not. And also, such child needs developmental screening. The other is about prognosis. With prompt diagnosis and treatment within first few weeks, patients can have normal growth and intelligence, but sometimes they might have reduced IQ, they might have other sequelae such as motoring coordination, short attention span, problems with reading, writing, and mathematics, difficult speech, and also 20% of them might have sensorineural hearing loss. The second is about acquired hypothyroidism. The most common cause for acquired hypothyroidism is chronic lymphocytic thyroiditis or Hashimoto's thyroiditis. Other causes of acquired hypothyroidism include hypothalamic or pituitary disease, associated with other diseases or syndromes such as Down's, Turner's, Klinefelter, type 1DM, Addison's disease, celiac disease, and multiple sclerosis. And also iatrogenic causes such as treatment with PTU, metimazole, lithium, radiation of thyroid area, radioiodine, thyroidectomy, large liver hemangiomas, and subacute thyroiditis rarely can cause hypothyroidism in children. When we see the most common cause of acquired hypothyroidism, that is chronic lymphocytic thyroiditis or Hashimoto's thyroiditis, or sometimes you can call it autoimmune thyroiditis. And many thyroid autoantibodies implicate in development of this disease. Thyroid antiperoxidase antibody, which is present in 90% of patients, is thought to be the most responsible one. And thyroglobulin antibody, which is also present in around 90% of patients. Thyrotropin receptor antibody and pendrin, which is a protein on thyroid follicular cell antibody present in 80% of patients. When we see the clinical presentation of acquired hypothyroidism, majority of acquired hypothyroidism are also seen in female, as in that of the primary hypothyroidism or congenital hypothyroidism. And commonly, the peak age for having acquired hypothyroidism is after 6 years of age, with peak in adolescence. And most present is with firm, non-tender asymptomatic goiter, and can be euthyroid but compensated, and overt hypothyroidism are the more common presentations. Sometimes they might have variable course. Patients can be euthyroid, have either resolution or diminished size of goiter, or progress to hypothyroidism. Sometimes hashimototoxicosis can happen. In this case, the patient can have sudden weight loss, heat intolerance or tremors, or symptoms of hyperthyroidism. And 5 to 10% of patients with autoimmune thyroiditis present with symptoms similar to hyperthyroidism. And this is a transient phase that occurs before onset of hypothyroidism. So this sign and symptoms of hyperthyroidism, which is called hashimototoxicosis, is not permanent. It is a transient phase. Later, the patient will develop overt hypothyroidism. Signs of hypothyroidism include lethargy and decreased energy, constipation, cold intolerance, slow growth, weight gain, delayed bone maturation, galactorrhea, pseudo-precocious puberty such as breast and testicular enlargement can happen. Most of the time, the bone age is younger than that of the patient's age. So, delayed bone maturation is the most common symptoms of hypothyroidism. The other is bradycardia, sluggish behavior, myxedema, delayed relaxation of deep tender reflex, such as Achilles tendon, and hypothermia, cold and dry skin, hoarse voice, brittle nails, and delayed dentition can happen. On investigation, as in that of the congenital hypothyroidism, free or bound T4 is decreased and the TSH is elevated, and we can also see thyroid peroxidase antibody because acquired hypothyroidism is mostly due to Hashimoto's thyroiditis or chronic lymphocytic thyroiditis. This autoantibody mediated disease, and the anti-thyroglobulin level can be raised also. When we see treatment of acquired hypothyroidism, if evidence of subclinical or overt hypothyroidism is there, L4 or levothyroxine is used, and if the patient is at euthyroid state, it needs only follow-up, and currently no treatment is needed. Although these can be self-limited, both groups require periodic re-evaluation because antibody levels fluctuate and they persist for many years. So this is all about hypothyroidism. On the next lesson, I will discuss about hyperthyroidism. Thank you for watching.